Hey, everyone. Good evening or good morning on the East Coast, but good evening in West Africa. My name's Dr. Amy Cassidy, and can you hear me?
Yes, we can hear you clearly.
Thank you. I am an
Yes, we can hear you. Thank you.
Good, yay. Okay. I am an obstetric anesthesiologist at Wake Forest University School of Medicine, which is in Winston-Salem, North Carolina. We're about 5 hours south of Washington, D.C., if that helps kind of envision where I am. I am going to talk to you today about maternal sepsis. And let me see if I can get my slides pulled up here real quick.
Yeah, you are very welcome.
Thank you so much. Yes.
Thank you.
Sure. And then go to full screen.
This thing. Okay. Okay, can you guys see my slides okay?
Yes, we can see your slide.
Okay.
And you know how to do laser point, right?
I forgot.
Right click.
It's okay. I can just use the.
They can't see that.
Yeah, they can. Okay. Yep, I got it. Okay. Thank you. Sorry, I'm not the most computer savvy. I have to have my technical assistant, my husband, help me get these things going. But I'm going to talk to you today about sepsis-related maternal mortality. This work, I'm going to be referencing some studies from Rwanda in this talk, and that is because last year, until COVID happened, I was a Fulbright scholar serving in Rwanda for on behalf of the United States, teaching obstetric anesthesiology, resuscitation, and obstetric critical care in the main teaching hospital in Kigali. And I was also supposed to be doing a research project on sepsis-related maternal mortality that unfortunately hit some roadblocks with ethics approval and then got cut short because of the pandemic and we had to come home early. So you will see some of my slides are referencing studies from Rwanda, and that's what I'm going to use as my background information. So giving birth should be your greatest achievement, not your greatest fear. And unfortunately, with high maternal mortality rates around the world increasing in high resource countries, and for the most part decreasing in low resource countries, unfortunately, when you become pregnant, there's some fear because a lot of women don't survive birth. And because of that, this quote was the kind of the central thesis of my Fulbright proposal, that, you know, our goal was to make childbirth and pregnancy a hopeful and wonderful experience rather than something that fills us with fear. Septic shock in particular is one of the leading killers of mothers worldwide. Septic shock is sepsis with concomitant circulatory and cellular or metabolic dysfunction. Septic shock is associated with a higher risk of mortality than sepsis is by itself. So you can see sepsis with signs of infection, sepsis accompanying an infection, but then when you progress into septic shock, you're starting to see a higher level of both circulatory and metabolic dysfunction, and that is what contributes to the higher risk of mortality in women. Every year, this is WHO data, 1 in 10 maternal deaths worldwide are due to sepsis. 1 in 10, that's a lot. And it's estimated that 75,000 maternal deaths every year are due to infection. So if we can find what's causing the infections, maybe we can figure out a way to to prevent these infections from progressing to sepsis and to septic shock, which is what ultimately causes mortality. Maternal sepsis is a life-threatening condition. Okay, so that's one of the things that is really important for us as physicians to be aware of, is that it's not just, oh, it's an infection, we need to give some antibiotics, blah, 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 take our time, see what happens. Maternal sepsis is life-threatening, right? So that means that we have to treat it like it's an emergency. We have to be on top of it and start with the early treatment quickly. And there's lots of resources out there that I'm going to review later in the lecture about how we go about treating that quickly and what the first step should be. But what we need to realize is that when we see organ dysfunction, like kidney failure, respiratory failure, cardiovascular collapse, coming as a cause of, as a result of an infection during pregnancy. It can happen during pregnancy, it can happen at childbirth or after childbirth. It can happen after an abortion, whether that's an abortion that's performed clinically or an abortion that's performed outside of the hospital in perhaps a less safe way. Infection can result in the postpartum period, and we'll talk more about why that happens. The important thing for us to know is that it can happen at any point along this spectrum, from during pregnancy to the end of pregnancy, and that when we recognize that there is an infection paired with this level of organ dysfunction, we have to think, okay, this is life-threatening, and what am I going to do about it? So a little bit of background data, and this is the data I'm talking about that comes from Rwanda. There was a study done in 2015 looking at the main teaching hospital in Kigali, which is where I was doing my work. It's called SCCM, or the University Teaching Hospital of Kigali. It's associated with the University of Rwanda College of Medicine and Health Sciences. And they did a study there looking at maternal near miss and mortality in this tertiary care hospital. So this hospital that I was in is the largest public hospital, and it's like there's 4 main referral centers, 3 of which are in the capital and 1 is about 3 hours south. So this is one of the main referral centers in the capital. What they looked at in the study was severe maternal mortality and severe maternal morbidity, which is the near miss cases that happened within that hospital in the 1-year period from October of 2011 to October of 2012. During that time, during that 1-year time, they identified 192 cases of severe near miss morbidity and mortality out of a total of 1,739 live births. And what they saw was that 90% of the patients with a severe obstetric morbidity were not patients who delivered there at SCCM. They were patients who delivered in a district hospital and then were referred to the tertiary center. And I'm sure this is similar to the pattern that you see in Nigeria. This is what I saw during work in Ghana as well, that what we see is patients that deliver at the tertiary center usually do well because best practices are in place, there's more resources available. So the care provided at the tertiary center tends to be of a little bit higher level than what's available in some of the district hospitals or outside of that in the health centers. And so the majority of patients that came in with severe morbidity and mortality were transfer patients from outside, which is an important finding because it helps us know where we need to target our interventions. The most common cause in this same study, the most common cause of the severe maternal morbidity was sepsis and peritonitis. Over 30% of the cases of severe morbidity and mortality was from sepsis and peritonitis. And what they saw was that 75 cases came from infection, 58 were due to peritonitis. 16 of the maternal deaths in this study were due to peritonitis, which gave a case fatality rate of 28%, meaning 16 out of the 58 patients that presented with peritonitis ultimately died from their infection. And that lets us know that there's likely a kind of minimum level of severe morbidity and mortality because we're not capturing all the data, right? And I know that in Nigeria, this tends to be a problem as well. You can't capture all the data from births that happen outside of the hospital, or in your case, such a large population spread out over such a large area. If it's difficult to capture data in Rwanda, which is a teeny tiny country compared to Nigeria with only 13 million people, you know, imagine what that is with a population 10 times that size and in such a larger catchment area. So this prevalence of sepsis and peritonitis following delivery is probably a gross underestimate, just because of the difficulty with capturing data. So this data is what came from this study at Sayashika, and it showed the different causes of maternal morbidity and mortality. And you can see, I mean, what comes up to the top, things like hypertensive disease, peritonitis, and hemorrhage, which are common across the world as the three main reasons that women die in childbirth. But peritonitis came in with the highest percentage, 30% of these cases, as far as their severe maternal morbidity and mortality rate. And I just highlighted that there for you. So if what we're seeing is that 90% of these cases presenting with severe morbidity and mortality come from district hospitals, then we need to look at the district hospitals. So this study was done by some of the same researchers that did the study I just presented to you. And what they looked at was the Ruhengeri maternity ward in the Musanze district of Rwanda. This hospital is a regional hospital. So this is one step down from the tertiary referral hospitals. It's located approximately a 3.5-hour drive from the capital. It's up in the mountains. It's difficult to transfer patients from here to the main hospitals in Kigali, but that is where they go when they have trouble. This is still a provincial referral hospital. So this hospital has good running water, electricity, some resources, not as many resources as are present in the tertiary referral hospitals, but this is still a hospital that receives transfers from more local district hospitals and health centers in the area. So in this hospital, they were looking at patients having maternal near miss and mortality in the period from June 2013 to December 2014, so about 18 months of study time. And what they found there was that 99 women had severe maternal outcomes. 86 of them were near misses and 13 were deaths. And this does not capture the deaths in patients who delivered there or were transferred there, but then transferred away from there to the main hospitals and died outside of this hospital. This only looks at the women who died at this hospital. And they found, once again, sepsis and peritonitis following cesarean deliveries had the highest mortality index. So once again, we're finding that if sepsis and peritonitis is the problem, the chance of death once that diagnosis is made is very high. And interestingly, only 18 of 38 women that were diagnosed with sepsis and peritonitis at this rural hospital received parenteral antibiotics. So that's something that's pretty basic and well studied. It has lots of evidence behind it that in women with infection, we should treat with appropriate antibiotics. However, in this case, they found that only less than 50% of these women were actually given IV antibiotics after being diagnosed with sepsis. So that right there is a target, something we could look at to improve. What they said, the authors found that particular attention is needed for conditions with a high mortality index, in particular post-C-section sepsis and peritonitis. And they felt that the relative inexperience from medical officers working in district hospitals, along with the improper use of antibiotics and perhaps poor sterilization procedures, could be potential contributing factors to the development of infection and peritonitis in these women. So this shows you the data, and I'm sorry, this part is very small, but I enlarged the part that I really want you to see, which is the interventions that would be recommended for women with sepsis. What we're seeing is that the use of antibiotics was low. The percent of cases that had severe maternal outcomes was relatively high, and there was noted to be a 5.3% mortality rate among people who had sepsis. So interestingly, and this is old data, but cesarean delivery has a 5 to 20 times higher rate of infection than vaginal delivery. So this gives us information that we probably need to target the cesarean deliveries if we're going to try to improve the rates of sepsis following birth. So, okay, we agree there's a problem. We agree that sepsis is bad in pregnancy. We agree we don't want mothers dying from infection after having babies. But like, what do we do about it? How can we prevent mortality when sepsis becomes a problem after delivery? So number one is, okay, if we can stop people from getting the infection before it happens, then we never go down the road of an infection becoming sepsis and sepsis becoming septic shock and patients dying. So number one step would be, let's try to prevent the infection. Let's nip this in the bud or stop it where it starts. The next step would be, okay, well, if an infection happens, then we need to diagnose sepsis early, because many studies have shown that the earlier we intervene in cases of sepsis, the more likely we are to be able to stop its progression before it progresses to septic shock and eventual mortality. So if we can notice sepsis, identify it early, then we can treat it. And what that means is that in patients who present with some kind of infection, we have to suspect that sepsis is a problem. We have to already have it in our head that, okay, this could be what's going on and this is what we need to do to treat it. And then the next step would be, if we have sepsis, then we need to act fast. This is an emergency. There are targets for things that we need to do within the first 1 hour, within the first 3 hours. And what I saw sometimes in Rwanda was just the time that it takes to coordinate, even in the tertiary referral centers, to coordinate care, as far as for the doctors to see the patient, evaluate the patient, give orders to the nurses to get things they need from the pharmacy and actually do things for the patient. That can take a lot of time. And I think impressing upon your staff the urgency of this situation, and that time is mortality. So every minute that you can save by acting quickly gives the mother a better chance of surviving. So since all sepsis starts with an infection, the first thing that we have to look at is that first step of infection prevention. And this begins at the level of the community. This is outside the hospital, before patients even come. If a patient has a planned cesarean delivery, or even if they're going to come in for a vaginal delivery, good hygiene on the part of the patient lowers the risk of infection. So in patients who are admitted to the hospital before delivery, if they can have a preoperative bath or shower to clean their skin, that would actually lower the risk of infection. Also, post-operative wound care and personal hygiene is important. So when patients are admitted to the hospital after cesarean delivery, as well as when they go home, they really need to be instructed on good wound care and keeping their wounds clean and dry. And so keeping their bodies clean until the time that their wound is completely healed, because primary wound infection is one of the main triggers that leads post-cesarean patients down the road to becoming septic. And patients also need to have access to safe water and sanitation. And this is a problem throughout the world that is way bigger than just us anesthesiologists, but at the community level, access to clean water and sanitary practices will definitely decrease the risk of infection that happens once patients go home. Safe food preparation. Good nutrition. As we know, good nutrition greatly impacts wound healing. So if patients can have access to, and this may be a higher level policy issue really, for postpartum mothers to have access to good nutrition, particularly during their wound healing period, they're less likely to become infected. But there's also things that we can do. So that's just kind of like what's possible in the community. And again, a lot of those things are outside the hospital, not things that we as physicians necessarily control, but things that we as physicians can advocate for on behalf of our patients, perhaps at a government level or policy or community level. Inside the hospital, though, we have things that we can do to prevent infection as well. And remember, we're talking about preventing the infection before it even starts, not treating an infection once it's already happened, but what can we do before we even get down the road of having an infection? And so the number one thing, the simplest, easiest, number one thing that all of us can do, and even us as anesthesiologists, even us as people who don't have our hands in the wounds, hand hygiene. This is very simple. This is washing your hands. And I don't just mean like surgeons scrubbing before they do an operation. I mean washing your hands when you take care of a patient, when you touch a patient, before you perform a spinal, before you start an IV, before you administer a medication, before you hook up an IV drip to the IV line, before a nurse is going to perform wound care on a postoperative patient, before a Foley catheter is placed. So hand hygiene in everything we do throughout medicine, whether that's physically washing your hands with soap and water or the use of an alcohol-based hand sanitizing gel, however it's done, we can affect infection prevention by 50%. We can reduce by 50% the number of infections that happen following delivery with just washing our hands, which is so simple and so easy for us. It has to become a habit. It's something that we have to work at. And even in my big teaching hospital in the United States, we are still struggling. And we have people who circle through the hospital, making sure that all of us are continuously washing our hands. And it's bizarre that even in a pandemic, it's hard to get some people to understand that they need to wash their hands. But that's, that would have a huge impact. If we could just get people to do hand hygiene, we would stop 50% of these infections right there, which means a significant decrease in mortality. Also, the cleanliness of the hospital environment. That means the theaters have to be clean. The equipment within them needs to be clean. The equipment needs to be sterilized properly. And there are sometimes the sterilization procedures that can contribute to the infection themselves by equipment being contaminated before it's used. Strict sterile technique has to be adhered to. That can be a difficult thing to teach your teams because you have different levels of education working in an operating room. You have physicians who presumably understand strict sterile technique, but then you also have nurses and technicians and orderlies who may not have the same understanding of sterile technique that the physicians do. The other thing is keeping the theater doors closed and limiting traffic in and out of the theater. So at the main teaching hospital in Rwanda where I was, the doors were usually left open because there's no air conditioning within the hospital. So it's not as hot there as it is in West Africa. The average temperature is, upper 70s Fahrenheit, but there's no, in order to have airflow, you have to leave the doors and the windows open. And you can see how leaving doors and windows open would be a possible contamination risk, allowing both air transfer between operating rooms, but also flies and bugs. The other thing was you had to go through one operating room to get to the recovery room. So there was often traffic, people walking back and forth through an operating room during surgery. So if that kind of thing is happening, that seems to be an easy fix, right? Create a different way a different route for people to get to the recovery room and make sure that the doors and the windows in the operating room can stay closed to reduce the risk of air contamination. Safe water and sanitation is important outside the hospital. It's also important inside the hospital. So having access to clean water and good sanitation as far as like toilets for the patients, toilets for staff, is very important, and keeping the hospital clean. There's also, in our hospitals, we have a lot of infection prevention and control programs. There are people whose entire job is to walk around the hospital and make sure that infection prevention measures are being followed and that infection prevention controls are being adhered to. So they will come and monitor, watch people to see how people are doing with hand hygiene. They'll test instrument sterility. They will follow patients through the process and watch every person that interacts with them and how they're, the cleanliness with which everything that's being done to the patient is being done. So having those programs in place can greatly impact your infection rates. Using antibiotics appropriately. So indiscriminate use of antibiotics, as we all know, greatly contributes to the risk of antibiotic resistance. So it was very inconsistent when we looked at the data in Rwanda. Sometimes patients would get the 1 dose of a first-generation cephalosporin at the time of their delivery and then get no more antibiotics, which is appropriate. Sometimes patients would just empirically be put on a 5-day course of antibiotics following delivery, which is unnecessary. I can see how that would happen because you think, well, if 1 dose of antibiotics is good, then more doses of antibiotics must be better. But actually what happens is continued exposure to the antibiotic creates antibiotic resistance in the organisms. And then so the organisms will not be treated by the same antibiotic in the future, which means that you need escalating levels of antibiotics till you get to a point that we don't have an antibiotic that can treat some of these bugs. So using antibiotics appropriately and by following guidelines will also reduce the risks of lethal infections. And then postpartum wound checks, making sure that on the wards, the patient's wounds are being checked, that they're clean, that their dressings are changed and kept dry, and that patients come back once they're discharged from the hospital. That's really important. Patients need to be instructed before they leave the hospital of things that they should come back for. This was something that we also noticed was potentially a problem in our patients, was that their discharge instructions, their nurses on the ward were often very overwhelmed and didn't have time to give each patient individualized discharge instructions. So one way that you could approach that would be to have the nurses every day give kind of like a discharge seminar to all the patients that are going home that day, gather them together at once, provide them with their discharge instructions, and during that instruction time, making sure that patients know how to care for their wound following cesarean delivery, and what to return to the hospital for. So if they see redness or drainage, or if they get a fever, that they should return to the hospital promptly, because the sooner they come back into the hospital system, the sooner we can act and hopefully prevent them from progressing to sepsis. This is from the WHO. They have a project on maternal sepsis prevention and treatment. And again, you can have these posters put up in your hospital. You can use these posters to teach your colleagues or to teach nurses on your wards so that they can understand that simple health measures like hand washing and good access to water and sanitation and using good infection prevention and control measures can decrease the risk of infection and therefore decrease your incidence of sepsis and ultimately maternal death. There's a WHO publication which is recommendations for the prevention and treatment of maternal peripartum infections. And if some of these practices are present in your hospital, you may know about them, even though they're not things that we necessarily do. If you see some of these things happening, you need to say something, right? And perhaps provide your colleagues with this particular coalition of information that came from the WHO and their evidence-based recommendations. Routinely shaving the perineum prior to vaginal delivery increases the risk of infection. There's no need to clean the vagina with chlorhexidine or betadine or any other prep for vaginal deliveries. Those things can actually increase antibiotic resistance. Likewise, using routine antibiotics or empiric multi-day antibiotic therapy is not necessary. Also, the WHO does not recommend giving antibiotics in any of these situations. So don't prophylactically hand out antibiotics during the 2nd or 3rd trimester just because you want to reduce the risk of infection. In women with preterm labor who have intact membranes, there's no reason to give antibiotics. The same with women whose water breaks at term. Great, that's a good thing. That's what helps put them into labor. There's no reason, just because their water's broken doesn't mean that they need to receive antibiotics. Meconium staining is not an indication for antibiotics. Use of a vacuum or forceps is not a reason to use antibiotics. Episiotomy should not be treated with empiric antibiotics. And anybody who has just a nice uncomplicated vaginal birth, they do not need to receive antibiotics following their delivery. Giving antibiotics in all of these situations is one of the things that, again, contributes to antibiotic resistance. So there are some things that the WHO says are a good idea. And so if these things are not happening in your maternity wards, then these are changes that can be made that will decrease the incidence of maternal infection. And in these situations, we're not just talking about wound infection following cesarean, but also reducing the decrease of endometritis following delivery as well, or vaginal infections. So if you limit vaginal exams in labor to every 4 hours, or have them be driven by changes in labor pattern or changes in pain, rather than just routinely checking the cervix every couple of hours or something, you can decrease how much bacteria are introduced into the vagina or into an open cervix. If you clean the vagina with a betadine or iodine solution before cesarean section, particularly in patients who have labored. So in our hospital, if a patient has labored, especially if they have ruptured membranes, but if they have labored before they go for their C-section, they get a betadine, povidone iodine vaginal prep prior to their abdominal prep for their cesarean delivery. We don't do this in women who are presenting for routine scheduled C-sections who haven't labored, but it is a good practice in all women having cesarean section. The abdominal prep that is locally appropriate. So the WHO doesn't have enough evidence to say that a betadine prep is superior or inferior to a chlorhexidine prep or a chlorhexidine and alcohol prep. So whatever prep is being used locally, as long as it is consistent from patient to patient and used on every patient, they're okay with that, whatever kind of prep works. And then a first-generation cephalosporin antibiotic should be given to every woman having a cesarean delivery prior to skin incision. I was in Bolivia a couple of years ago, and during cesarean deliveries, we found that they were only giving antibiotics if the surgeon requested them. And the surgeons were not following WHO recommendations. So the incidence of infection was higher, and they couldn't really understand why that was happening. And it came down to, if you give a first-generation cephalosporin, a drug like, we use cefazolin for all of our deliveries, and that's what we had available in Rwanda as well. But a first-generation cephalosporin given intravenously before skin incision is made has been shown as best practice to decrease the risk of infection following cesarean deliveries. Okay. So other things that we should do, according to the WHO. We should give antibiotics to women in labor who are group beta strep positive. Routine group beta strep testing is not done in Rwanda, so I'm not sure if that's something that you're doing in Nigeria, but in the United States at 35 weeks of pregnancy, all women receive rectal and vaginal swabs to test for the presence of group beta strep bacteria. That can also be tested on a urine sample. So when women who are known to have positive group beta strep colonization of the genital tract, they're treated with antibiotics while they're in labor to prevent the risk of transmission of that infection to their newborns. Anybody who has premature preterm rupture of membranes should receive antibiotics. If the placenta has to be manually removed, the women should receive antibiotics. If there's a 3rd or 4th degree tear, now remember, we said we don't give antibiotics for an episiotomy, but a 3rd or 4th degree tear, because it can involve contamination from the rectum, should be treated with antibiotics. Anyone who has chorioamnionitis should be treated with ampicillin and gentamicin. And women with postpartum endometritis obviously should receive antibiotics as well. And usually in that case, it would be clindamycin and gentamicin. But, okay, so we do all these things, right, to try to prevent an infection from happening. But if, despite our best efforts, despite everything we do, we still have infection happen, then what we need to do is immediately switch into, okay, we couldn't prevent the infection, but now we have to try to prevent death. We have to prevent mortality. The number one thing, and this is one of the problems that in the hospital, we can't control this, but as community advocates, something we can control is that patients need to know when to come back to the hospital. Time is life in cases of sepsis-related mortality. So if we can convince patients that they need to promptly seek medical care in the course of an infection, then we have a chance to affect them before it progresses beyond a point from which we can save them. And so teaching patients when to return to the hospital, but also teaching the community hospitals, the health centers, the district hospitals, when an infection has become sepsis and when that patient needs to be transferred to a higher level of care is very important as well. This starts with how we teach doctors and nurses during their training, but can also be taught during trainings at the local hospitals. Teach the staff to recognize the signs of infection and transfer the staff in other hospitals need to know how to detect sepsis early. They need to know the signs and symptoms, and they need to know what to do right away. So to initiate the first steps, if they detect sepsis, the first steps would be prompt treatment with antibiotics and supportive care, like with IV fluids, and we'll get more into that. But in order to have early detection, we have to know we have a problem, which means we have to be looking for it. We kind of have to be suspecting it. So every time a patient presents with an infection, we have to have it in our head, okay, is this patient in sepsis? Are they likely to proceed to sepsis? And if they do, what can I do about it? So again, the WHO has provided this information that for us in poster form. All of this is available online, and you can use that. You could post this on labor and delivery units. You can make this available for staff. They need to know that if a patient has fever or if the patient has hypothermia. So if the patient presents cold, it's just as ominous as with a high fever. And sometimes people are falsely reassured, well, the patient doesn't have a fever, but their temperature is low. And low temperature can be just as much a sign of sepsis as high fever can. So if they have fever, and then the presence of any of these following signs or symptoms, tachycardia, hypotension, signs of respiratory distress, if they're jaundiced, if they're not making as much urine as normal, you know, postpartum or pregnant women should be urinating all the time in large volumes. So if they have decreased urine output, that's a concern, as well as altered mental status. So any patient that presents with altered mental status in the postpartum period, sepsis needs to be ruled out, okay? Even though we may think, okay, it could be eclampsia, it could be a stroke. There's other things that can cause altered mental status, but if we're keeping it in the back of our head that, okay, that can also be a sign of sepsis, then we will recognize sepsis earlier and perhaps intervene. The most important thing that everyone who encounters these patients needs to understand is that if these signs or symptoms are seen, that sepsis is an emergency, which means everyone needs to act quickly on the behalf of the patient. So what do we do? How do we act? Well, the early management of sepsis consists first of restoring volume. Okay, sepsis is a form of distributive shock, and so in all types of shock, except for cardiogenic shock, we're going to resuscitate, beginning with the administration of IV fluids. Crystalloid is fine. You do not need to resuscitate with colloid. You need to give 30 cc's per kilo. In an American patient, that would be about 3 liters because they're all around 100 kilos. But in the rest of the world, you probably have more of a 50 kilo patient. So you're looking at about 1.5 liters of IV crystalloid in the first 3 hours just to get their resuscitation started. So large volume fluid resuscitation quickly, which means you need good IV access. You also need to give IV antibiotics. I will show you in a moment which antibiotics are important, but if you suspect wound infection or peritonitis, IV antibiotics need to be started early. Ideally, if this patient is presenting to an outside a district hospital or health center, they need to receive the antibiotics there. This is something that needs to happen within the first hour. We need to identify and treat the source of the infection. If we have sepsis, but we don't know where the infection is coming from, we need to look. Do they have a wound infection? Do they have a vaginal infection? Is it endometritis? Is it peritonitis? What is it? Is it pneumonia? I mean, there's other causes of infection, right? Is it pyelonephritis? So we need to know what is the source of this infection and start the treatment for it. And then these patients need to be transferred to specialized care early, right? If sepsis progresses, they need critical care management. They're not going to be able to be managed with just fluids and IV antibiotics. So any patient that presents with sepsis needs to be transferred to a higher level of care where critical care services are available in case they progress to that level. Norepinephrine is the pressor of choice in sepsis. It should be targeted, titrated to target a MAP of at least 65 or higher. So they need to be started on a norepinephrine infusion if crystalloid resuscitation doesn't quickly restore their blood pressure. And we need to be able to monitor vital signs. So again, this is something that may not be possible at an outside facility, whether that's a resource issue or a staffing issue. If the patient cannot be have their vital signs closely monitored, then they need to be transferred to a level of care where they can, because we need to know if our blood pressure interventions are working. So I mentioned antibiotics, and for all of us, we're like, well, but which antibiotic? What antibiotic should I pick? And just throwing antibiotics at these infections willy-nilly is not the answer. For abdominal infections, the Society for Maternal and Fetal Medicine recommends these 3rd-generation cephalosporins for the treatment. So if you have ceftriaxone or cefotaxime, you can use one of those in the treatment of specifically for peritonitis. If your issue is endometritis, then you're going more with ampicillin and gentamicin. So once you've prevented the infection, oh, but it wasn't prevented, now we have an infection, then we have to recognize that the patient is septic. And if they're septic, then we need to act fast to treat sepsis. And so this is another one of the WHO posters that is a summary of the recommendations that I just went over with you. This is what you need to do first. Give IV fluids, give IV antibiotics, figure out where the infection is coming from and treat it, get them transferred to a facility that has critical care services, and make sure that you're able to monitor the vital signs of the mother, and if she's still pregnant, the fetus as well. The Society for Critical Care Medicine developed the Surviving Sepsis campaign, and they have what they describe as the Hour One bundle, which I'm sure you're familiar with. But this is something that I keep on my phone, and if I am encountering a patient with infection, I pull it up and go through it every single time, because in an emergency, I don't want to trust my brain to remember. So things like this can be very helpful. But if you have a patient that presents with infection and potentially sepsis, you need to identify that they are septic, and then you need to begin this bundle and try to, as hard as you can, to achieve these 5 things in the first hour following the diagnosis of sepsis. So if available in your facilities, you would like to measure a lactate level. And if the lactate level is higher than 2 millimoles per liter, you want to be able to remeasure it later as a marker of improvement in sepsis, okay? The second thing is, if possible, you want to draw and send blood cultures before you give any antibiotics. If obtaining blood cultures is a time limiting factor, if that's something that's going to take a long time because either blood culture vials are not available, or someone to draw the blood is not available, don't delay giving antibiotics just because you want to obtain blood cultures. Best practice would be get blood cultures and immediately start antibiotics. But if it's going to take an hour or 2 or 3 to get blood cultures drawn, just go ahead and start antibiotics. Number 3 is to administer broad spectrum antibiotics. Number 4, to begin that rapid administration of 30 milliliters per kilo of crystalloid. If the patient is hypotensive or if their lactate level comes back higher than 4. If you don't have access to a lactate level, that's totally fine. You just need to be able to, you can base it based on the patient's blood pressure. And then number 5 would be if the patient remains hypotensive despite fluid administration, or if while you're giving fluid, the patient's blood pressure continues to be low or declines, then you want to start pressor therapy, typically with norepinephrine. Although if norepinephrine is not available to you, whatever pressor you have is better than nothing. And your goal is to keep their MAP, their mean arterial pressure, 65 or higher. The biggest point of my presentation today is that our goal is happy, healthy moms and happy, healthy babies. And in order to achieve that goal, we have to have the knowledge and the skills to not only prevent infection, but be suspecting sepsis, recognize it, and act fast to treat it so that we can have this be our end result and not maternal mortality. So I'd like to thank you for your presence today and hope you gained something from this presentation. My family standing on our balcony in Kigali last year. And below is my email address. If you have any questions or if you'd like copies of my slides, you can email me and I'll be happy to share them with you.